Hey guys, tonight we're diving into something that has absolutely no business being as wild as it is. The story of Ozempic. Not the glossy TV commercials, not the celebrity confessions, not the before and after photos flooding your social media feed. I mean the real story. How a drug that was never ever designed to make you thin accidentally became the most talked about pharmaceutical since aspirin. So before you get too comfortable, take a second to like the video and subscribe, but only if you genuinely enjoy what I do here. And a truly warm thank you to whoever suggested this topic. You know who you are, and honestly your brain is doing the Lord's work. These suggestions are what make this channel something I'm genuinely proud of. Drop a comment letting me know where you're listening from and what time it is for you. There's always someone tuning in at 2 a.m. in a country I've never heard of, and somehow that delights me every single time. Also, if you prefer to take the show on the road, we're now on Spotify. Link is in the description. Go find us there, save it, and drift off to history wherever you are. Now, dim those lights, turn on a fan, pull the blanket up to approximately chin level, wiggle your toes once, yes, just once, and let your shoulders drop. Good. Because here's what I want you to think about before we begin. Have you ever wondered how a scientist in Denmark working on lizard spit, I said what I said, accidentally set off a global cultural earthquake? Have you ever wondered what a Gila monster has to do with your co-worker who suddenly looks like a different person? Did anyone in a laboratory in the 1970s think, you know what, this hormone thing we're studying for diabetes might one day dominate the red carpet? Could something this world-changing really have started with a blood sample from a reptile the size of a football? And more importantly, why did it take 40 years for anyone to notice? Congratulations. You've just woken up in a pharmaceutical laboratory sometime in the early 1970s. There are no smartphones, no social media, and absolutely no one standing around saying, this is going to end up on a podcast. What there is, a lot of pipettes, a lot of confused scientists, and somewhere out in the desert, a very unbothered lizard who has no idea what he's about to start. Let's start at the beginning. Not a lab, not a boardroom, a desert. Specifically, the sun-scorched scrublands of the American Southwest, where a thick, slow-moving reptile called the Gila monster has been minding its own business for millions of years. Scientists in the 1970s weren't exactly swarming the desert looking for diet breakthroughs. They were doing the kind of quiet, unglamorous research that fills up journals nobody reads. But one curious detail about the Gila monster kept nagging at them. This animal could go months without eating, and yet its blood sugar stayed remarkably stable. For a creature that basically treated fasting as a lifestyle, that was medically bizarre. And in science, bizarre is always interesting. The Gila monster is not, by any reasonable measure, a glamorous animal. It is slow. It is stubby. It spends most of its time wedged under a rock, conserving energy with the dedication of someone who just got a new streaming subscription. It eats maybe 10 times a year, large meals of eggs, small mammals or other lizards, gobbled down and then metabolized at a pace that would make a sloth feel hurried. And here is the thing that made biologists lean forward in their chairs. During those long stretches of nothing, the Gila monster's blood sugar didn't spiral into dangerous territory the way you might expect. It held, steady, patient, like it knew something the rest of biology hadn't quite figured out yet. What was keeping it balanced? That was the question that started everything. Researchers studying metabolic regulation, the way bodies manage energy, sugar, and fat, began looking at the hormonal systems operating in animals like the Gila monster with new curiosity. Not because anyone had a master plan, not because someone had a vision of a weekly injection changing the shape of Hollywood in 50 years, but because when something in nature works in a way that shouldn't, the honest scientific response is to pull on the thread and see what unravels. And this is worth pausing on, because it says something important about how science actually works which is almost nothing like how it looks from the outside. Nobody funded the Gila monster research because they thought it would produce a blockbuster drug. Nobody had a roadmap. There was no investor presentation with slides titled Phase 1, Desert Lizard, and Phase 2, Profit. There was just a handful of curious people, a pile of questions, and enough institutional patience to let them keep asking. The kind of science that changes the world rarely announces itself. It usually shows up looking like something that probably won't go anywhere. What the researchers eventually identified, and we'll get deeper into the biology in a moment, was that the Gila monster's saliva contained a compound that acted on the same receptors as a hormone found in the human gut. A hormone that, it turned out, had everything to do with hunger, insulin, and the body's relationship with food. The compound in the lizard system was structured differently from the human version in one critical way. It lasted much, much longer before breaking down. In the human body, the equivalent hormone disappeared in minutes. In the Gila monster system, the effect lingered. And in pharmacology, duration is everything. So there it is. The origin story of one of the most talked about drugs in modern history begins not in a gleaming research facility, not in a corporate strategy meeting, but in the desert, with an animal that could go half a year without eating and never seem particularly bothered about it. The Gila monster didn't choose to change medicine. It was simply, stubbornly, improbably itself. And for once that was enough. Now let's get slightly technical, but only slightly, because this is a sleep show, and nobody wants to do a pharmacology exam at 11:30 at night. Buried deep in the gut is a hormone called GLP-1, or glucagon-like peptide 1. Say it once, never say it again, we'll just call it GLP-1. It's released after you eat, it tells your pancreas to make insulin, it slows down digestion, and crucially, it signals your brain that you are full. It's basically your body's built-in, okay, put the fork down memo. The problem is, in people with type 2 diabetes, this system is broken. The memo gets lost. The fork does not go down. Scientists in the 1970s and 80s were just beginning to understand this, scratching their heads over a hormone so short-lived in the bloodstream, it barely registered before it disappeared. 2 minutes. That is how long GLP-1 survives in the human bloodstream before enzymes chew it up and it vanishes. 2 minutes. You have had thoughts that lasted longer than that. You have stood in front of an open refrigerator for longer than that. The human body produces this hormone, releases it, and then immediately destroys it, which from a design perspective seems like a tremendous waste of effort. But biology is not an engineer working from a blueprint. It is millions of years of imperfect tinkering, and the system worked just well enough for most of human evolutionary history, when people were not eating 3 meals a day plus snacks, plus a late-night visit to whatever the Paleolithic equivalent of a kitchen cabinet was. GLP-1 is produced in cells lining the small intestine, cells called L cells, if you'd like something to forget immediately, and it is released in response to food arriving in the gut. When it hits the pancreas, it prompts the release of insulin proportional to how much sugar is in the blood. This is actually quite elegant. Unlike some older diabetes treatments that pushed insulin production, regardless of blood sugar levels, creating the risk of dangerous lows, GLP-1 only triggers insulin when glucose is actually present. The pancreas gets the message and responds accordingly. Clean, targeted, sensible. The problem is that in type 2 diabetes, this whole signaling chain degrades. The L cells are less responsive, the pancreas is overworked, and the feedback loops that keep blood sugar stable begin to fray. For decades, this hormone sat in the scientific literature like a promising lead that nobody quite knew what to do with. It was documented. It was described. Researchers knew what it did in general terms. But knowing what a hormone does and knowing how to make it medically useful are two very different problems. The first problem is biology. The second problem is chemistry, manufacturing, clinical trials, regulatory approval, and about 15 years of work that nobody glamorizes because it is mostly very difficult and very slow and punctuated by results that say, promising but insufficient more often than any reasonable person would find encouraging. What researchers needed was a version of GLP-1 that didn't evaporate in 2 minutes. Something that could survive long enough in the body to actually do its job. Something stable, manufacturable, and safe to inject. The natural version was too fragile. It needed, in pharmaceutical terms, to be engineered, and that engineering would take longer than anyone wanted, involve at least one large lizard, and ultimately produce something that nobody had set out to create in the first place. As origin stories go, it is not fast, but it is real, and real is, in the end, the only kind that matters. Not every scientific breakthrough comes from a dramatic eureka moment. Sometimes it comes from one extremely stubborn person who simply refuses to accept that something is impossible. In this case, that person was a Danish researcher named Jens Juul Holst, who spent decades, not years, decades, quietly obsessed with GLP-1. While the rest of the scientific world moved on to more glamorous research, Holst stayed. He was the kind of scientist who would show up to a conference talking about gut hormones and watch people slowly inch toward the cheese table. But he kept publishing, kept presenting, kept insisting this obscure little hormone mattered. He had no idea he was right in a way that would eventually end up on the cover of every magazine in the world. Holst began his serious work on GLP-1 in the 1980s at the University of Copenhagen, in the kind of research environment that rewards patience more than pizzazz. He was not working on a hot topic. Gut hormones were not where ambitious young scientists planted their flags if they wanted grant money and recognition. But Holst was not chasing recognition. He was chasing a question. Why did this hormone behave the way it did, and what could it mean for people with diabetes? Those were the only questions he needed. What made Holst unusual, apart from the tenacity that his colleagues described with the particular admiration reserved for people you would never personally want to emulate, was his refusal to be discouraged by the hormone's central inconvenience. The 2-minute lifespan problem, the degradation problem, the problem that made GLP-1 scientifically fascinating and practically useless in its natural form. Where others looked at this and saw a dead end, Holst looked at it and saw a puzzle. He published papers, he trained students, he corresponded with researchers around the world who were working on related questions. He built, slowly and without fanfare, the intellectual infrastructure that would eventually make Ozempic possible. There is something almost melancholy about this kind of scientific career, viewed from the outside. The years of work that don't make headlines, the grant applications, the conference presentations to half-empty rooms, the slow accumulation of data that nobody outside a narrow specialty will ever read. And then, decades later, the world catches up. The phone starts ringing. The journalists want quotes. The Nobel Prize Committee starts taking an interest. By the time Holst was being celebrated as one of the founding fathers of the GLP-1 drug revolution, he had been working on this problem for longer than most of the journalists writing about him had been alive. His collaborators over the years described him as relentlessly curious, almost constitutionally incapable of considering that he might be wasting his time. That quality, the refusal to accept that a question is too small or too obscure to be worth pursuing, is rarer in science than the public tends to imagine. Funding pressures push researchers towards safe bets and incremental results. The people who stay on unfashionable problems for 30 years are a particular kind of person. They are not always easy to be around. They are almost always indispensable. When patients inject semaglutide today in Denmark, in the United States, in every country where the drug has reached, they are the downstream beneficiaries of one man's refusal to move on. He did not invent Ozempic. He built the foundation it was built on, brick by patient brick, in a laboratory in Copenhagen, while the rest of the world was not paying attention. Science has a word for this kind of contribution. The word is essential. Back to the lizard. In the 1980s, a scientist named John Eng was working at the Veterans Affairs Medical Center in New York, not exactly the setting you'd imagine for a biological revolution. Eng had a peculiar hobby, hunting through the venom and saliva of exotic animals for compounds that might have medical uses. The Gila monster's saliva contained a peptide, a tiny chain of amino acids that behaved remarkably like human GLP-1. Not just similar, eerily, impossibly similar. The difference was that this lizard version lasted far longer in the bloodstream. It didn't vanish in 2 minutes like the human version. It stuck around. Eng called it Xendin 4, filed a patent, and then spent years trying to convince pharmaceutical companies that the Gila monster's spit was, in fact, a medical goldmine. As you can imagine, the pitch meetings were awkward. John Eng was not a flashy scientist. He was methodical, precise, and possessed of a research interest that most of his colleagues considered, at minimum, eccentric. His work on animal venoms and salivary compounds occupied a corner of biology that mainstream medicine didn't spend much time visiting. But Eng had a theory. Evolution had been running chemical experiments for hundreds of millions of years, and some of those experiments had produced compounds with properties that human pharmaceutical chemistry hadn't yet managed to replicate. You just had to look in the right place, or, in this case, in the right reptile's mouth. The discovery that Xendin 4, the compound from Gila monster saliva, activated the same receptors as human GLP-1 was striking enough on its own. But the durability was the revelation. The human hormone vanished in 2 minutes. Xendin 4 lasted hours. The structural difference between the two molecules was subtle but significant. A single amino acid substitution that made the lizard compound resistant to the enzyme that normally chews up GLP-1. It was as if nature had accidentally engineered the solution to the problem that was preventing GLP-1 from being medically useful. In a lizard, in its spit. Eng filed his patent in 1990, and then, as happens with many genuinely important discoveries, nothing much happened for a while. He approached pharmaceutical companies. He made his case. He explained patiently and repeatedly that here was a naturally occurring compound that mimicked and outlasted human GLP-1, which had known implications for diabetes treatment, which had been characterized and documented, which was ready for someone with resources to develop into an actual drug. The responses range from polite disinterest to something close to bafflement. The Gila monster, as a source of pharmaceutical inspiration, was not an easy sell. It took until the early 2000s for Amylin Pharmaceuticals and Eli Lilly to license Eng's patent and develop Xendin 4 into a drug called exenatide, branded as Bietta. It was approved by the FDA in 2005, 15 years after Eng's patent filing, as the first GLP-1 receptor agonist available for clinical use. It required twice-daily injections and produced modest results. It was not the revolution, but it was proof of concept. It confirmed that the mechanism worked in humans, that the approach was sound, and that the Gila monster had, in its slow and unassuming way, been pointing at something real. John Eng received credit, eventually partially in the way that science sometimes credits its more unusual contributors. The Gila monster received none. It continues to live in the desert, eating sporadically, maintaining stable blood sugar, and remaining entirely unaware that it changed medicine. Some would call that a shame. Most Gila monsters, if you could ask them, would probably say they prefer it that way. To understand why Ozempic eventually became what it became, you need to understand the landscape of type 2 diabetes treatment in the late 20th century. It was bleak. Patients were given medications that worked, sort of, but came with side effects ranging from unpleasant to genuinely miserable. Weight gain was common. Hypoglycemia was a constant threat. Insulin injections were effective but burdensome and deeply intimidating to newly diagnosed patients. Meanwhile, the number of people developing type 2 diabetes was climbing at a rate that should have terrified governments into immediate action. It didn't. Mostly because the problem wasn't dramatic. Nobody collapsed in the streets. It was a slow, grinding, largely invisible epidemic, eating its way through populations one pancreas at a time. Type 2 diabetes is, at its mechanical core, a problem of insulin resistance. The body produces insulin, the hormone that allows cells to absorb glucose from the blood, but the cells stop responding to it properly. The pancreas, trying to compensate, pumps out more. Eventually it exhausts itself. Blood sugar rises and stays high, and elevated blood sugar, sustained over years, is quietly catastrophic in ways that don't announce themselves all at once. It damages blood vessels, it damages nerves, it accelerates kidney disease, heart disease, and vision loss. It is the leading cause of adult-onset blindness in many countries. It is the leading cause of non-traumatic limb amputation. None of this is fast. None of it is visible in the way a broken arm is visible. But all of it is real, and all of it was happening to more and more people every year. The treatments available through most of the 20th century were, by modern standards, a rough toolkit. Metformin, still widely used today, was effective and inexpensive but caused significant gastrointestinal side effects that patients found difficult to tolerate. Sulfonylureas stimulated the pancreas to produce more insulin but did so indiscriminately, creating the risk of blood sugar dropping dangerously low. Insulin itself worked, but requiring patients to inject themselves multiple times daily, monitor their blood sugar constantly, and calibrate doses carefully was a significant burden, one that many patients struggled to maintain, particularly after initial diagnosis when the reality of a lifelong condition was still settling in. And here was the cruel irony baked into almost all of these older treatments. Several of them caused weight gain, which mattered enormously, because weight gain makes insulin resistance worse, which makes diabetes harder to control, which requires more medication, which can cause more weight gain. It was a trap with walls that moved inward the harder you pushed against them. Patients and doctors both knew this. Nobody had a great solution. By the 1990s, the global prevalence of type 2 diabetes was rising sharply, driven by urbanization, dietary shifts, reduced physical activity, and an aging population. The World Health Organization was using the word epidemic with increasing frequency. Researchers were under pressure to find better treatments, not just treatments that controlled blood sugar, but treatments that addressed the underlying metabolic dysfunction, that were tolerable long-term, that didn't make the weight problem worse. The bar was not impossibly high, but it had not been cleared. Not yet. The GLP-1 researchers, working quietly in their corner of endocrinology, were building towards something. The field just didn't know it yet. In a country best known for pastries and Vikings, a small Danish pharmaceutical company called Novo Nordisk had been quietly obsessed with insulin since the 1920s. They weren't a flashy company, they didn't make anything sexy. They made diabetes drugs, and they made them steadily, methodically, with the sort of Nordic patience that suggests someone is in it for the very long haul. By the 1990s, they had their eye on GLP-1. The science was compelling, the unmet medical need was enormous, and someone at Novo Nordisk made the decision to commit. It would take years of failure, reformulation, and the occasional bout of scientific despair before they had anything worth putting in a needle. But they kept going. Because that is what companies betting on hormones do. They wait. Novo Nordisk's origins are inseparable from insulin. The company was founded in Denmark in the 1920s, shortly after insulin was discovered, and it built its entire identity around the manufacture and improvement of this one essential molecule. For decades, that was enough. Insulin kept people with type 1 diabetes alive. It was not glamorous work, it was manufacturing, purification, formulation, scale, but it was work of genuine and measurable importance. The company grew slowly, carefully, and with the institutional caution of an organization that had learned, early, that the people depending on its products could not afford mistakes. By the time GLP-1 research was producing interesting results in academic labs in the 1980s and 90s, Novo Nordisk had the infrastructure, the scientific capability, and crucially, the strategic patience to invest in a hormone that might take 20 years to become a drug. They partnered with researchers, funded studies, and began the slow chemical work of engineering a GLP-1 analogue that could survive in the human bloodstream long enough to be therapeutically useful. Their first approved GLP-1 drug was liraglutide, branded as Victoza, which required daily injections and was approved for type 2 diabetes in 2010. It worked. It improved blood sugar control. And the weight loss side effect, which patients began reporting almost immediately, was noted. What Novo Nordisk did next was the decision that made everything else possible. Rather than treating the weight loss as an interesting footnote, they studied it. They ran trials specifically designed to measure the effect of liraglutide on body weight, not as a secondary endpoint but as a primary one. Those results, under the brand name Saxenda, a higher dose formulation approved specifically for weight management in 2014, were encouraging enough to push them toward the next generation of the molecule. They went back to the chemistry. They looked at what made liraglutide work, where it fell short, and how to build something better. The result of that effort was semaglutide. The distance between a good idea and a commercial drug is measured in years, money, failure, and bureaucratic endurance that would defeat most reasonable people. Novo Nordisk covered that distance by treating GLP-1 not as a gamble, but as a commitment, a multi-decade investment in a biological pathway they believed in, when the evidence was early and the commercial case was uncertain. The scientists who worked on liraglutide and then semaglutide did not know they were building toward a cultural phenomenon. They were building toward a better drug for people with diabetes. The rest of it, as they sometimes say in understated Danish offices, came later. Let's talk about what drug development actually looks like, because it is the opposite of what anyone imagines. You do not have a great idea on Monday and a pill on Friday. You have a great idea on Monday, followed by approximately 15 years of clinical trials, regulatory submissions, safety reviews, failed reformulations, unexpected side effects, a global financial crisis, and at least 3 moments where someone in a meeting says the words, "Maybe we should pull the plug." The early GLP-1 drugs that emerged in the 2000s, Bieta, based on that Gila Monster compound, and later Victoza, Novo Nordisk's own liraglutide, were genuine medical advances. They worked, doctors were pleased, patients' blood sugar improved. And then someone noticed something strange in the trial data. Patients were losing weight. Not a little. Noticeably. Drug development has a formal structure that exists in theory to protect people. In practice, it also takes so long and costs so much that only large, well-capitalized organizations can sustain it. Phase 1. Trials test safety in small groups of healthy volunteers. Phase 2 trials test whether the drug does what you think it does, in patients who have the relevant condition, at doses that seem reasonable. Phase 3 trials are large, expensive, multi-year studies designed to confirm efficacy and surface side effects that might not appear in smaller groups. The whole process, from early compound to approved drug, typically takes between 10 and 15 years, and cost somewhere between $1 and $3 billion. This is by any measure an extraordinary amount of time and money to spend on something that might still fail at the last step. And they do fail regularly. The pharmaceutical industry's failure rate in clinical development is somewhere around 90%, meaning 9 out of 10 compounds that enter human trials never reach approval. Most fail for reasons that are genuinely hard to predict. The drug doesn't work as well in large populations as it did in early studies, or it works but produces a side effect that only appears in 1 in 10,000 patients, which you won't catch until you've treated thousands. The science that got you to the clinic is rarely the science that gets you across the finish line. For GLP-1 drugs, the clinical development process involved solving several interlocking problems simultaneously. The chemistry problem. How do you modify the GLP-1 molecule so it survives in the bloodstream long enough to be useful? The formulation problem. How do you create an injectable product that is stable at room temperature, manufacturable at scale, and tolerable for patients to self-administer? The regulatory problem. How do you design trials that will satisfy the FDA's requirements for both efficacy and cardiovascular safety? Because after several high-profile cardiovascular disasters with older diabetes drugs, regulators now require extensive heart safety data for any new diabetes medication. Semaglutide addressed all of these. Its molecular structure was modified to bind to albumin, a protein in the blood, which protected it from the enzyme that destroys natural GLP-1. This gave it a half-life of approximately 1 week, making once-weekly dosing possible. The manufacturing process was refined over years. The cardiovascular trial called SUSTAIN-6 showed not only that semaglutide didn't hurt the heart, but that it appeared to protect it. By the time the FDA reviewed the application, the package was unusually strong. The approval in December 2017 was almost anticlimactic. The hard part had happened in the years before anyone was watching. Here is the moment. Not in a movie-style flash of inspiration, not with dramatic music, just a quiet pattern emerging in spreadsheets. Patients in GLP-1 trials for diabetes were reporting something their doctors hadn't asked about and hadn't expected. They weren't hungry, not a bit less peckish. They described something more profound, a near silencing of the constant background noise of food thoughts that most people don't even realize they experience until it stops. They ate less, almost without deciding to. They lost weight as a byproduct of a mechanism nobody had specifically designed for weight loss. The scientists looked at the data. They looked at each other. And somewhere in a very understated Scandinavian office, someone probably said, in Danish, something that roughly translates to, that's interesting. Clinical trials collect an enormous amount of data. Beyond the primary endpoints, the specific things a trial is designed to measure, there are secondary endpoints, exploratory analyses, and patient-reported outcomes that capture information about how people's lives are changing on the drug. In the GLP-1 trials designed to measure blood sugar control, body weight was tracked as a secondary measure. It was expected that patients might lose a small amount of weight because reducing blood sugar often has modest metabolic effects. What was not expected was how much weight patients were losing, and more importantly, why they were losing it. The mechanism, as it became clear, was not simply metabolic efficiency or reduced caloric absorption. It was behavioural in the most fundamental sense. Patients were eating less because they wanted less food. The appetite suppression was not the white-knuckled kind, the kind where you want something desperately and force yourself not to have it. It was something quieter and stranger. The wanting itself had diminished. Patients described eating a few bites of a meal and feeling genuinely, comfortably satisfied in a way they hadn't felt before. They described walking past food they would previously have found irresistible and feeling simply nothing much. It was not deprivation. It was the absence of compulsion. Researchers understood in broad terms why this was happening. GLP-1 receptors are present not just in the pancreas and the gut, but in the brain, specifically in regions governing appetite, reward and satiety. When semaglutide activates those receptors, it is doing something at the level of brain chemistry, not just digestion. The hypothalamus, the brain region most directly involved in regulating hunger, receives a persistent signal that resources are adequate, that eating is not urgent, that the alarm can stand down. This is a simplification, but it is not a misleading one. The drug is, in effect, hacking a very old biological alarm system, and for many patients, the alarm had been going off continuously, exhaustingly, for years. The weight loss findings from the early GLP-1 trials were significant enough that Novo Nordisk did what any rational company with a promising data signal would do. They designed trials specifically to measure it. This was the beginning of a parallel development pathway: diabetes drug on one track, weight loss drug on another, same molecule running down both simultaneously. The clinical and commercial logic was obvious. The medical need for effective obesity treatment was enormous. The mechanism appeared to work. The only question was how well and how safely and for how long. Those questions would take years to answer. But the direction was set in the way that directions always are in science, by a result nobody was looking for. By the 2010s, Novo Nordisk's scientists had spent years engineering a better version of the GLP-1 molecule, one that lasted longer, worked more efficiently, and could be injected just once a week instead of once a day. They called the resulting compound semaglutide. It was, in the dry language of pharmaceutical science, a GLP-1 receptor agonist. In human language, it was a synthetic version of a hormone that told your body it had eaten, slowed digestion to a crawl, and sent signals to the brain that food was no longer an urgent priority. It was not magic. It was not a shortcut. It was the result of decades of research, thousands of failed compounds, and one extremely cooperative lizard whose contribution to global health has never been properly acknowledged. Let's take the chemistry slowly, because it is genuinely interesting once you get past the nomenclature. The natural GLP-1 molecule is 94% identical to semaglutide. The changes Novo Nordisk's chemists made were small but strategically critical. They substituted one amino acid in the chain to make the molecule resistant to the enzyme, called DPP4, that normally degrades GLP-1 within minutes. They then attached the modified molecule to a fatty acid chain, which allows it to bind loosely to albumin, the most abundant protein in the blood. Albumin acts as a slow-release reservoir. Semaglutide binds to it, travels in the bloodstream, releases gradually, and is protected from rapid clearance. The half-life of natural GLP-1, 2 minutes. The half-life of semaglutide, approximately 1 week. Same basic molecule, radically different behaviour. What semaglutide does once it is circulating is multifaceted in ways that researchers are still fully mapping. At the pancreas, it stimulates insulin secretion in the presence of elevated blood sugar, the glucose-dependent mechanism that makes it safer than older diabetes drugs, which could drive insulin levels too low regardless of blood sugar. At the stomach, it slows gastric emptying, the rate at which food leaves the stomach and moves into the small intestine, which extends the physical sensation of fullness and flattens the blood sugar spike that follows a meal. In the liver, it reduces glucose production. In the cardiovascular system, it appears to have anti-inflammatory effects that contribute to the reduction in heart attack and stroke risk observed in clinical trials. And in the brain, it acts on GLP-1 receptors in regions governing appetite and reward in ways that alter, at a neurochemical level, the intensity of hunger and food-seeking behaviour. This last mechanism is what most people are actually talking about when they discuss Ozempic's effects. The metabolic benefits are real and clinically significant. But what patients describe, the quieting of food noise, the diminished urgency of appetite, the altered relationship with eating, is happening in the brain, not the stomach. And that distinction matters, both clinically and culturally, because it reframes what the drug is doing. It is not simply suppressing appetite in the crude way that older weight loss drugs did. It is modulating a neurological system. It is changing the signal, not just blocking it. Semaglutide is not a perfect drug. No drug is. Its side effects, predominantly nausea, vomiting, and other gastrointestinal symptoms, particularly in the early weeks of use, are real and significant enough to cause some patients to discontinue. Its long-term effects on muscle mass are a legitimate concern. Its cost is prohibitive without insurance. Its supply has proven insufficient to meet demand. But as a pharmacological achievement, as the end product of the chain that began with a desert lizard and a stubborn Danish scientist, it is, by any honest assessment, remarkable. Not because it is perfect, because it works. Semaglutide went through the gears of regulatory approval with all the fanfare of a very important but extremely boring government document. Ozempic, the injectable form, was approved by the FDA in December 2017 for type 2 diabetes management. Nobody threw a party. There were no red carpets, no morning show segments. A diabetes drug had been approved. Endocrinologists were pleased. Diabetologists were interested. The general public was entirely unaware. For about 3 years, Ozempic lived exactly where it was designed to live, in the quiet, crucial, unglamorous world of metabolic medicine. Prescribed to people with type 2 diabetes by doctors who were cautiously impressed by how well it controlled blood sugar. And then the internet noticed the weight loss. The FDA approval process for Ozempic followed the standard pathway, with one significant addition. The agency required, as it now does for all new diabetes drugs, a dedicated cardiovascular outcomes trial. This requirement was introduced after a diabetes drug called rosiglitazone was found, after approval, to increase the risk of heart attacks. The resulting scandal changed the regulatory landscape significantly. New diabetes drugs now had to prove not just that they controlled blood sugar, but that they did not harm the heart, and ideally, that they helped it. Semaglutide's cardiovascular trial, called SUSTAIN-6, enrolled over 3,000 patients with type 2 diabetes who already had established cardiovascular disease or were at high risk for it. The trial ran for approximately 2 years. The results, published in the New England Journal of Medicine in 2016, showed that semaglutide reduced the composite risk of major cardiovascular events, heart attack, stroke, and cardiovascular death, by 26% compared to placebo. This was not a neutral result. This was a positive one. The drug wasn't merely safe for the heart, it appeared to protect it. The FDA noted this in the label. Cardiologists noted it in their practices, and Novo Nordisk quietly began to understand that they might have something larger than a diabetes drug on their hands. But the approval was for diabetes. The label said type 2 diabetes. The dosing was calibrated for blood sugar management. The marketing, such as it was aimed at endocrinologists and primary care physicians managing diabetic patients. The television commercials, when they came, were gentle and clinical, a cartoon pancreas, an explanation of insulin, a reassuring voiceover mentioning nausea as the most common side effect. Nobody watching those commercials was particularly inspired. Nobody was sending them to their friends. The drug settled into the formulary. Pharmacies stocked it. Doctors prescribed it. And for 3 quiet years it was simply a very good diabetes drug with an interesting side effect that patients occasionally mentioned at follow-up appointments, with a kind of slightly sheepish enthusiasm, as though they were reporting something they weren't sure they were supposed to notice. Then 2020 arrived, and with it, a global pandemic, a collective reckoning with bodies and health and mortality, a surge in social media use, as people sat at home with their phones, and a growing network of patients comparing notes online about what their medications were doing to them. The stage had been set for a long time. It was simply waiting for a spark. It didn't start with celebrities. It started the way most cultural shifts start, with people talking to each other. Doctors began noticing that their patients on semaglutide were asking different questions at checkups. Not just is my blood sugar better, but is it supposed to work this well for weight? Patients were mentioning it to friends. Friends were mentioning it to their own doctors. A trickle of online posts appeared, not from influencers, from ordinary people, describing a relationship with food that felt fundamentally different. The phrase food noise entered the conversation, that relentless, low-level hunger chatter that runs in the background for many people, and suddenly there was a name for something millions had experienced but never articulated. And once something has a name, it spreads. The whisper network that built around GLP-1 drugs in 2020 and 2021 operated through the channels that health information now travels. Reddit forums, Facebook groups, comment sections, and the early stages of what would become a significant TikTok conversation. The communities that formed were not primarily composed of people trying to lose weight for aesthetic reasons. They were composed of people with type 2 diabetes, people with obesity-related health conditions, people who had struggled with their weight for decades and were experiencing for the first time a pharmacological intervention that seemed to work in a way nothing had before. The tone of these early discussions was one of slightly bewildered gratitude. What people described consistently and across groups that had no contact with each other was the food noise phenomenon, and the description had a remarkable uniformity. People talked about having spent their entire adult lives with a mental frequency running in the background, a constant low-level awareness of food, what was available, when they would eat next, how they could justify having or not having something, a background hum of food-related calculation and anxiety that they had assumed was simply who they were. And then, on semaglutide, the hum stopped, not reduced, stopped. Many described walking past food that would have previously triggered an intense, effortful act of willpower and feeling simply neutral, as though the food was there in the way a fire hydrant is there, present, irrelevant. This description was disorienting to people who heard it from outside the experience, because it implied something that many people had long suspected, but that society has historically refused to accept, that for a significant portion of the population, the relationship with food is not primarily a matter of willpower, character, or discipline. It is neurological. It is a difference in how the brain's hunger and reward systems are calibrated, a difference that, for those who have it, is as real and involuntary as any other neurological variation. The drug was not helping people try harder. It was changing the underlying signal. That distinction was everything, and it travelled quietly at first through every message thread and comment section where people were comparing notes on what their medication was doing to their heads. By late 2021, the whisper network had grown loud enough to be audible in clinical practices across the country. Doctors were fielding requests, pharmacists were fielding questions, and somewhere in the orbit of celebrity, someone with a platform was about to make it considerably louder. Somewhere around 2021, something shifted in the way certain famous people looked. It was subtle at first, the kind of thing you noticed but couldn't quite pin down. Then the gossip column started muttering. Then the page 6 items appeared. Then a comedian made a joke at an award show, and suddenly Ozempic was the most Googled word in the country. The drug had been prescribed off-label for weight loss for some time before this moment, but the celebrity spotlight accelerated everything. Suddenly, the quiet diabetes medication was a Hollywood secret, a status symbol, and depending on whom you asked, either a miracle or a moral failing. Novo Nordisk, a company that had been making unremarkable-seeming diabetes drugs in Denmark since before World War II, was now a household name. The mechanics of how Ozempic became a celebrity drug are not particularly mysterious. Wealthy people have access to concierge medicine, boutique clinics, and physicians who are attentive to new options and willing to prescribe off-label. When a drug produces visible results that show up in photographs, that prompt questions at events, that travel through the networks of people who know each other and observe each other closely, information moves fast. Hollywood is, among other things, an industry in which physical appearance has professional consequences. It is also an industry in which treatments that work become open secrets relatively quickly. What accelerated the celebrity Ozempic story from industry whisper to public phenomenon was the awards season cycle of 2022 and 2023, where the pace of visible physical transformation among certain highly photographed people became difficult to attribute solely to previously undisclosed lifestyle changes. The tabloid speculation started, as it always does, with anonymous sources and careful euphemisms. Then came the more direct commentary, mostly from comedians, who have historically been the people willing to say the thing that everyone is thinking but that polite culture pretends not to notice. The jokes were mixed in their generosity. Some were cruel, some were perceptive. All of them put a word on television that had previously lived only in waiting rooms and Reddit threads: Ozempic. The cultural moment that followed was complicated in the way that conversations about bodies and weight are always complicated. On one hand, here was genuine medical information about a drug that was helping people, breaking through decades of failed treatments for a condition that had serious health consequences. On the other hand, the version of this story being told on entertainment news was almost entirely aesthetic, about how people looked, not about what the drug was treating, or why it existed, or who had developed it, or who genuinely needed it. The diabetes patients who'd been quietly and successfully using the drug for years watched the celebrity coverage with a mixture of feelings. Awareness was good. The framing was something else. And somewhere in Denmark, a pharmaceutical company was looking at their order books and beginning to understand that they were not prepared for what was coming. Let's spare a thought for the endocrinologists and primary care physicians caught in the middle of all this. The ones who had been prescribing semaglutide carefully, for the right patients, for the right reasons, and who suddenly found their waiting rooms full of people who'd seen a TikTok. These doctors were in an impossible position. On one hand, the clinical evidence for semaglutide's weight loss effect was genuinely strong. On the other hand, the drug had been designed for people with type 2 diabetes, and the global supply was finite. Turning away a patient with obesity-related health risks felt wrong. Turning away a person with type 2 diabetes who could no longer get their medication felt worse. The waiting rooms were full, the fax machines were going, and nobody had planned for this. The physicians at the center of the Ozempic wave were operating in several directions at once, and all of them were uncomfortable. From one side came patients with legitimate medical needs for weight management, people with obesity-related health conditions, elevated cardiovascular risk, metabolic syndrome, for whom semaglutide was a medically appropriate option, and who deserved access to effective treatment. From another side came patients who had been managing type 2 diabetes with Ozempic for months or years, and who were now being told at the pharmacy that there was no stock. From a third direction came a surge of requests driven by social media, by aesthetic motivation, by celebrities, by people who had heard about the drug in a context entirely divorced from its medical purpose and who wanted access immediately. For many physicians, the off-label prescribing question was genuinely difficult. Prescribing a drug off-label for an indication not listed on the approved label is legal and common. Doctors do it regularly, based on clinical judgment and available evidence. The evidence for semaglutide's weight loss effects was strong enough by 2022 that prescribing it for obesity in patients without diabetes was medically defensible. The higher dose formulation, Wegovy, had been specifically approved for weight management the previous year, though its supply was also constrained. But defensible and straightforward are different things. Doctors had to weigh the needs of individual patients in front of them against a supply-side reality that meant every prescription filled for one person might mean one fewer available for someone else. Some physicians began instituting informal protocols, prioritizing patients with diabetes, with cardiovascular risk, with BMI thresholds. Others deferred to whoever showed up first. Telehealth platforms, which had proliferated during the pandemic and which operated with less friction than traditional clinical settings, began offering semaglutide prescriptions with varying degrees of medical rigor. Clinics advertised weight loss programs featuring the drug with the urgency of a limited-time offer. The clinical context that had originally surrounded the drug, the careful monitoring, the adjustment of doses, the management of side effects began in some corners to fray. The doctors who had built their practices around responsible prescribing watched this with the particular anxiety of people who knew exactly what could go wrong. Supply chains are not exciting. Nobody lies in bed at night thinking about pharmaceutical manufacturing capacity. And yet, in 2022 and 2023, the Ozempic shortage became front-page news in a way that pharmaceutical supply chain stories simply do not. Novo Nordisk had not built their production infrastructure for a global weight loss revolution. They had built it for a diabetes drug. Their fill and finish facilities, their active ingredient production, their distribution networks, all calibrated to a much smaller demand. When demand exploded, the shelves emptied. People with type 2 diabetes, the patients the drug had been developed for, the patients who needed it for blood sugar management, began calling pharmacies and being told there was no stock. The irony was staggering and not funny at all. Manufacturing a biological drug like semaglutide is not like manufacturing aspirin. You cannot simply decide on a Tuesday to produce twice as much by Friday. The active ingredient is synthesized through a complex chemical process involving multiple steps, specialized equipment, and strict quality controls that cannot be rushed without risking product quality or safety. Scaling up production requires new facilities, new equipment, trained personnel, and regulatory validation, each of which takes years and hundreds of millions of dollars. Novo Nordisk had been scaling, but they had been scaling toward the demand they could model based on the diabetic population and the expected uptake of Wegovy. Nobody had modelled for Ozempic becoming a viral cultural phenomenon. The shortage hit different populations differently. People with type 2 diabetes who had been stabilized on semaglutide and who faced the prospect of switching medications with the blood sugar disruption that entailed were disproportionately harmed. Many of these patients had tried multiple previous medications without adequate control. Semaglutide had been the drug that finally worked. Being told it was unavailable was not an inconvenience, it was a medical problem. Patient advocacy groups began speaking loudly and publicly. Physicians wrote op-eds. The FDA added Ozempic to its drug shortage list, a designation that creates certain regulatory flexibilities but does not conjure more product out of thin air. Novo Nordisk responded by investing billions in manufacturing expansion, new facilities in Denmark, in France, in the United States, pledging to increase production capacity significantly over the following years. They also took measures to limit distribution to patients with diabetes attempting to channel supply toward the population with the most urgent medical need. These measures were imperfect. The grey market for compounded semaglutide, versions of the drug manufactured by compounding pharmacies outside Novo Nordisk's supply chain, of variable quality and uncertain safety, grew rapidly to fill the gap. The FDA issued warnings. Patients faced with a choice between a compounded version of uncertain provenance and no drug at all made difficult decisions. The shortage revealed in sharp relief the gap between demand for a treatment and the infrastructure capable of delivering it. Here is where the story gets slightly complicated in a way that requires you to stay awake for just one more minute. Semaglutide had two names depending on the dose and the indication. Ozempic, at lower doses, approved for diabetes. Wegovy at higher doses, approved specifically for weight management in 2021. They were chemically the same drug. Different branding, different doses, different regulatory pathways. Novo Nordisk had done the work, they'd run the trials, collected the data, gone through the FDA process, specifically to have a weight loss approval. But by the time Wegovy launched, Ozempic had already become the cultural phenomenon, and most people used the names interchangeably. For the purposes of this story, and for your ability to sleep tonight, just know, same molecule, two hats. The decision to develop semaglutide along two parallel tracks, one for diabetes, one for weight management, reflected a strategic clarity at Novo Nordisk that was not always visible from outside the company. They'd seen the weight loss data from the Victoza and early Ozempic trials. They understood what the STEP trials, designed specifically to measure weight outcomes at higher doses, were likely to show. They built the regulatory case for Wegovy carefully and in parallel with Ozempic's diabetes indication, anticipating that the weight loss approval would eventually create a large new market. What they did not anticipate, or at least did not plan for at manufacturing scale, was the timing and ferocity of that market's arrival. The FDA approval of Wegovy in June 2021 came with real clinical weight. The pivotal trial had shown an average weight loss of approximately 15% of body weight over 68 weeks, which was unprecedented for a pharmacological treatment. The agency approved it for adults with a BMI of 30 or higher, or 27 or higher, with at least one weight-related health condition. The labeling was clear, the medical need was substantial, and the launch, in commercial terms, began reasonably well, before supply problems, combined with the Ozempic cultural moment that arrived shortly after, created a situation where both drugs were simultaneously under pressure from demand that neither manufacturing line had been configured to meet. The confusion between Ozempic and Wegovy, same drug, different doses, different approved uses, frequently conflated in media coverage, had real consequences. Patients asking for the weight loss drug were sometimes given the lower dose diabetes formulation. Patients stabilized on Ozempic for diabetes were sometimes switched to Wegovy, or vice versa, as pharmacies managed variable stock levels. The two-brand strategy that made perfect regulatory sense created, in the context of shortage and high public interest, a communication challenge that proved genuinely difficult to resolve. The companies could not simply tell the public that Ozempic was a diabetes drug and Wegovy was a weight drug, and hope that clarity would stick in the face of everything the culture was doing with those names. In 2021, the results of the STEP trials, a series of clinical studies specifically designed to measure semaglutide's effect on body weight, were published. The numbers were not subtle. Participants lost on average around 15% of their body weight. Some lost significantly more. This was not the 2 or 3% that previous weight loss drugs had managed. This was the kind of result that made researchers check their numbers twice, then check them again. The comparison being drawn, quietly at first, then loudly, was to bariatric surgery, a drug achieving outcomes that had previously required an operating room. The scientific community absorbed this with the controlled excitement of people trained to distrust results that seemed too good. The general public, when it got wind, was less restrained. The STEP program, STEP standing for semaglutide treatment effect in people with obesity, comprised 4 major trials examining different populations and contexts. Step 1 enrolled adults with obesity or overweight, with at least one weight-related condition, without diabetes, and compared weekly semaglutide injections to placebo over 68 weeks. Step 2 looked at adults with type 2 diabetes. Step 3 examined semaglutide combined with intensive behavioral therapy. Step 4 tested what happened when patients who had achieved weight loss on semaglutide were then switched to placebo, a design intended to answer the maintenance question. Together, the trials enrolled thousands of participants across multiple countries, generating a dataset of considerable size and robustness. The results of Step 1 were the ones that landed hardest. An average weight loss of 14.9% of body weight in the semaglutide group compared to 2.4% in the placebo group. Approximately a third of participants lost more than 20% of their body weight. These were numbers that had not been seen in pharmacological trials for obesity before. For context, the best results previously achieved with approved weight loss medications typically ranged from 5 to 10% of body weight, and even those results had been achieved with drugs that carried significant safety concerns, drugs that had been pulled from the market after cardiovascular problems emerged, or that had abuse potential, or that work through mechanisms with uncomfortable neurological side effects. Semaglutide appeared to work better than any of its predecessors, with a side effect profile that, while real, was manageable for most patients. The bariatric surgery comparison, while inexact, was not frivolous. Gastric bypass surgery produces average weight loss in the range of 25 to 35% of body weight, with significant and lasting metabolic improvements. Sleeve gastrectomy produces somewhat less, but still substantial results. These procedures are major surgeries, carrying real operative risks, requiring significant post-operative lifestyle adjustment, and available only to patients who meet specific criteria and can access and afford the procedures. The idea that a weekly injection might approach, even if not match, the outcomes of surgery, without the operating room, without the recovery, without the permanent anatomical alteration, was genuinely paradigm-shifting. It did not go unnoticed by surgeons, by insurance actuaries, or by the millions of people who had been told for years that surgery was their best option if everything else had failed. The most unexpected part of the Ozempic story, the part that researchers hadn't fully anticipated, and that patients described with almost eerie uniformity, was the quieting of what became known as food noise. Most people, particularly those who struggle with weight, describe a constant low-level mental preoccupation with food. Not necessarily hunger in the physical sense, but a background frequency, what's available, when the next meal is, what you'd rather be eating, whether you've eaten too much, whether you'll eat again soon. For patients on semaglutide, this noise, which most had assumed was simply a personality trait, a weakness of will, went quiet. Many described it as revelation. Not just weight loss, but the sudden awareness that the noise had been there all along, followed by its inexplicable absence. The term food noise was not coined by a researcher. It emerged organically from patient communities, from the forums and support groups and comment sections where people on GLP-1 drugs were comparing experiences. It spread because it named something that had been unnamed. People who had spent decades being told that their weight was a matter of discipline, that they simply needed to try harder, that the solution was to want it more, found in this phrase an articulation of something they had felt but never been able to explain to people who didn't experience it. The noise wasn't metaphorical. It was a persistent, effortful, energy-consuming mental activity that occupied a portion of consciousness continuously and had, for years, been filed under the category of personal failing. The neurological basis for this phenomenon, while still being studied, points to the GLP-1 receptor activity in the brain's reward pathways. The same systems that are activated by food, the dopamine pathways that create the pleasurable anticipation and satisfaction of eating, appear to be modulated by semaglutide in ways that reduce the salience of food cues. In simpler terms, food becomes less interesting. The brain does not light up in the same way when it sees or smells or thinks about food. This is not a cognitive change. It is not a matter of thinking differently about food. It is a change in the automatic preconscious response. The thing that happens before you decide how to feel about it. For people whose brains had been generating strong and frequent food-related signals, the quieting was disorienting in its completeness. Researchers studying addiction medicine noticed something significant in these patient reports. The description of food noise and of its absence closely resembled description patients give of substance cravings. The persistent preoccupation, the intrusive thoughts, the effort required to resist, and the relief when it stopped of not having to fight that battle continuously. This observation reoriented for some researchers the entire question of what obesity is and how it should be treated. If the experience of weight-related overeating resembles, neurologically, the experience of addiction, compulsive, driven by brain chemistry, not primarily a matter of choice, then the treatments that work should logically be the ones that address the neurological signal, not the ones that demand more willpower from people whose neurological environment is already working against them. Things got uncomfortable fairly quickly. A drug that was in short supply, expensive without insurance coverage, and associated with celebrity use became, almost immediately, a class flashpoint. On one side, people arguing that access to an effective treatment for obesity should not be determined by wealth, that obesity is a medical condition, and that denying treatment based on cost is a public health failure. On the other side, people arguing that the drug was being hoarded by the wealthy for cosmetic purposes, while people with type 2 diabetes went without. And underneath all of this, a much older, much darker cultural conversation about weight, bodies, willpower, and who deserves medical intervention. Ozempic did not create that conversation, but it turned up the volume until you couldn't ignore it. The economics of the situation were stark. The list price of Ozempic in the United States without insurance was approximately $900 per month. Wegovy, the higher dose weight loss formulation, was higher still, around $1,300 to $1,500 monthly. For patients with commercial insurance covering diabetes medications, Ozempic was often covered. For patients seeking Wegovy for weight loss, coverage was inconsistent. Many commercial insurers covered it, many did not, and the criteria varied enormously. For patients on Medicaid or Medicare, coverage was largely unavailable. The drug that was transforming the weight loss conversation was, for a significant portion of the population that stood to benefit most from it, financially out of reach. The class dimension was not merely about who could afford the drug, it was also about who was being praised for using it. The celebrity Ozempic conversation was largely aesthetic, focused on thinness as an achievement, on before and after transformations, on the visual evidence of bodies that had changed. In this framing, the drug was a tool for looking better. The people who needed it most for health reasons, people in lower income brackets who faced higher rates of type 2 diabetes and obesity, often as a result of food environments, healthcare access disparities and chronic stress, were neither the face of the cultural conversation nor the people most likely to access the drug. The optics were uncomfortable in a way that nobody in Novo Nordisk's marketing department had anticipated, because the optics were not Novo Nordisk's doing. They were the culture's doing. Meanwhile, the diabetes community found itself in the peculiar position of watching a drug they depended on become famous for something other than what they used it for, and of absorbing the supply consequences of that fame. Patient forums filled with accounts of pharmacies out of stock, of rationing, of switching to less effective medications under protest. The emotional register of these posts was not anger, exactly. It was something closer to weary recognition, the recognition of people who had been managing a chronic illness for years, who had finally found a medication that worked, and who were watching that medication be depleted by forces that had nothing to do with their health. It was a story about access, and inequality, and the collision between a medical need and a cultural moment. And it was not resolved quickly. If you have ever tried to get an insurance company to cover something that works, you will not be surprised by what happened next. Despite clinical evidence, despite FDA approval, despite the well-documented health consequences of obesity, many insurers balked at covering GLP-1 drugs for weight management. The costs were significant, several hundred to over $1,000 a month without coverage, and insurers cited everything from concerns about long-term use to frankly circular logic about whether obesity was a disease serious enough to warrant treatment. Medicare, which covers tens of millions of older Americans, was prohibited by law from covering weight loss drugs, a restriction that dated back decades and suddenly looked like a policy designed for a different era. Patients, doctors, and patient advocacy groups began a fight that is still ongoing. The insurance landscape for GLP-1 drugs in the United States is a mosaic of contradictions that would be comic if the consequences were not so significant. Ozempic, approved for type 2 diabetes, is covered by most insurance plans as a diabetes medication, because insurance companies have, for decades, recognized diabetes as a serious condition warranting pharmaceutical treatment. Wegovy, approved for obesity, faces a far more hostile coverage environment because the insurance industry has, for decades, treated obesity as either a lifestyle choice or a less serious condition than its comorbidities, which is medically indefensible but financially convenient. The same molecule, at a higher dose, with a different FDA indication, triggers a completely different insurance response. The arbitrariness of this is not accidental, it is structural. The Medicare prohibition deserves particular attention because of its reach and its irrationality. The law governing Medicare's drug coverage, established in 2003, explicitly excluded weight loss drugs from coverage, a provision written at a time when the available weight loss medications were of limited efficacy and questionable safety, and when obesity was not yet formally classified as a disease. By 2023, none of those original conditions still held. Obesity had been reclassified as a chronic disease by the American Medical Association. The available drugs were effective, the cardiovascular data was compelling, and Medicare was still prohibited from covering them by a provision that nobody had the political will to revisit despite the changed landscape. The Treat and Reduce Obesity Act, legislation that would expand Medicare coverage of anti-obesity medications, had been introduced in Congress repeatedly for years and had not moved. The Congressional Budget Office's cost estimates for covering GLP-1 drugs under Medicare were large enough to cause significant political hesitation. The calculation being made implicitly was about short-term budget lines rather than long-term healthcare costs, a calculation that healthcare economists argued was deeply misleading because the cost of untreated obesity in hospitalizations and comorbidities and lost productivity far exceeded the cost of the drug. This argument was correct. It was also, for most of the period covered by this story, politically insufficient. The battle continued. Once Novo Nordisk's results were clear, The pharmaceutical industry did what the pharmaceutical industry does. It mobilized. Eli Lilly had been working on their own GLP-1 drug, tirzepatide, brand name Mounjaro, later Zepbound, that targeted not one but two hormonal pathways simultaneously and was producing weight loss results in trials that exceeded even semaglutide's impressive numbers. Other companies launched crash development programs. The science of GLP-1 and related receptors, which had been a quiet academic backwater for decades, was suddenly the most competitive real estate in drug development. Researchers who had spent years being politely ignored at conferences were now fielding phone calls from venture capitalists. Jens Juul Holst, the stubborn Danish scientist who had spent decades insisting GLP-1 mattered, was not surprised. Tirzepatide, Eli Lilly's entry into the race, is worth understanding in some detail because it represents a meaningful advance beyond first-generation GLP-1 drugs. Where semaglutide targets only the GLP-1 receptor, tirzepatide is a dual agonist. It activates both the GLP-1 receptor and another receptor called GIP, or glucose-dependent insulinotropic polypeptide. GIP is another gut hormone involved in insulin regulation and, it turns out, in appetite and fat metabolism. The combination of both signals in a single engineered molecule produced weight loss results in clinical trials that exceeded those of semaglutide, an average of approximately 20% of body weight in the pivotal trial, with a substantial proportion of patients losing more than a quarter of their body weight. The trial results, published in the New England Journal of Medicine in 2022, landed with the force of confirmation. This was a drug class, not a single drug, and the competition within it was going to produce rapid improvement. Beyond Lilly and Novo Nordisk, the drug development pipeline expanded rapidly. Companies including Pfizer, Amgen, AstraZeneca, and dozens of smaller biotechs announced GLP-1 programs or related metabolic hormone programs. The investment followed the science. If GLP-1 receptor agonism produced these results, what did triple receptor agonism produce? What about oral formulations, which would eliminate the need for weekly injections and dramatically expand the addressable population? Novo Nordisk itself was developing an oral version of semaglutide, eventually approved as Rybelsus, a daily tablet, and working on next-generation compounds. The entire metabolic hormone space, which had been underfunded relative to its potential, was suddenly awash in capital. The researchers who had built this field over decades watched the gold rush with mixed emotions. The investment was good, it would accelerate the science, produce more data, bring better drugs to patients faster. But science funded by urgency and competitive pressure is not always the same as science funded by curiosity. The questions being prioritized were the commercially legible ones. The foundational research that had made all of this possible, the patient, unglamorous work on GLP-1 biology, was now being extrapolated at a pace that occasionally outran the underlying evidence. The field had gone, in the space of a few years, from neglect to frenzy. Both extremes have their problems. Not everything about the GLP-1 story is uncomplicated. As more data accumulated, a concern emerged that doctors began taking seriously. Patients on semaglutide were losing not just fat but lean muscle mass. The body, when losing weight rapidly, does not always distinguish between tissues as neatly as we'd like. Studies suggested a meaningful proportion of weight lost on these drugs was muscle, not fat, which matters both for long-term metabolic health and for the basic physical functioning of daily life, particularly in older patients. Researchers began discussing the importance of resistance exercise and adequate protein intake alongside the medication. It was a reminder that a drug solving one problem can quietly create another, and that the full picture of any treatment takes years of real-world data to emerge. The concern about muscle mass is not specific to GLP-1 drugs. It is a feature of any significant weight loss, from any cause. When the body loses weight rapidly, it mobilizes energy from multiple tissue types, not exclusively from fat. Lean mass, muscle, is metabolically active and energy expensive to maintain, and under conditions of caloric restriction, the body will sacrifice some of it along with fat. The clinical literature on bariatric surgery had documented this for years. Patients who lost large amounts of weight following gastric bypass or sleeve gastrectomy also lost significant lean mass, with consequences for muscle strength, physical function, and long-term metabolic rate. The data emerging from GLP-1 trials suggested that the proportion of weight lost as lean mass was meaningful. Estimates ranged widely across studies, but some analyses suggested that muscle might account for a quarter to 40% of total weight lost on semaglutide. For a younger patient who is physically active and consuming adequate protein, this may be manageable. For an older patient who already faces age-related muscle loss, a condition called sarcopenia, and who may not be engaging in regular resistance exercise, it is a more significant concern. Muscle mass is closely tied to physical function in older adults. The ability to rise from a chair, to climb stairs, to maintain balance and avoid falls. Losing substantial muscle mass in pursuit of weight loss can, in some populations, trade one set of health risks for another. The clinical response to this concern has been to emphasize resistance exercise and protein intake as essential adjuncts to GLP-1 drug therapy, not optional additions, but necessary components of responsible treatment. Guidelines from obesity medicine societies began specifying protein targets for patients on these drugs and recommending supervised strength training where possible. Some researchers began investigating whether combining GLP-1 drugs with other agents, including drugs that specifically promote muscle preservation, might allow the benefits of weight loss to be captured without the lean mass cost. The field was adapting. That it needed to adapt was a reminder that no drug solves a problem in isolation, and that the downstream consequences of effective treatment are themselves problems worth solving carefully. Here is the thing about a drug that works while you take it. You have to keep taking it. Studies following patients who discontinued semaglutide found that the majority regained a significant portion of the lost weight within a year. Not all of it, but enough to make the question of long-term use both a medical and an economic conversation. The drug was not a course of treatment. It was, for many patients, more like a blood pressure medication, something that managed a chronic condition for as long as you used it. For people with the financial means or the insurance coverage to continue indefinitely, that was manageable. For everyone else, it raised questions about what the point of treatment was if it couldn't be sustained. Questions that don't have comfortable answers. The rebound data came from the Step 4 trial, which had enrolled patients who had already completed a 20-week run-in phase on semaglutide and achieved meaningful weight loss, then randomized them to either continue the drug or switch to placebo. The placebo group, the people who stopped the drug, regained an average of approximately 2/3 of their previously lost weight within a year. Their metabolic improvements, including blood pressure and blood sugar control, also largely reversed. The drug had worked. Stopping the drug worked in reverse. The implication was clear. This was not a treatment you completed and moved on from. It was a treatment you continued, possibly indefinitely, to maintain its effects. This finding generated significant cultural discomfort. The prevailing narrative around weight loss, one deeply embedded in Western culture, is one of transformation and maintenance through willpower and habit change. You lose the weight, then you keep it off, through discipline and lifestyle. The idea that obesity, for many people, requires ongoing pharmacological management in the same way that hypertension or high cholesterol does not fit this narrative. It implies that the underlying condition, the altered metabolism, the dysregulated hunger signaling, the neurological difference, is not corrected by treatment but managed by it. That is, in fact, how most chronic diseases work. But obesity has been treated culturally as something categorically different from other chronic diseases, and the rebound data bumped hard against that categorization. For healthcare economists and insurers, the rebound question has practical implications. If a patient must remain on a $1,000 a month drug indefinitely to maintain health benefits that disappear upon discontinuation, the cost calculus for coverage decisions becomes considerably more complex. The savings from reduced cardiovascular events and diabetes complications, which are real and well documented, must be set against the lifetime cost of the medication. This calculation is being actively worked through by health systems around the world with varying conclusions. Some systems have determined that the long-term economic case for coverage is strong. Others are waiting for more data. And many patients, in the meantime, are making the decision about whether to continue or stop based not on what medicine recommends, but on what their bank account permits. TikTok did not create the Ozempic phenomenon, but it accelerated it into something none of the drug's designers could have imagined. Videos of people describing their experiences, their weight loss, their side effects, their insurance battles, their moral ambivalence, their joy, their grief, all of it poured into the algorithm and poured back out into the feeds of millions of people who had never considered the drug before. Patient communities formed online with thousands of members sharing dosing tips, managing side effects, navigating insurance denials, and processing the strange emotional experience of having a physical relationship with food fundamentally altered by a weekly injection. The information was sometimes excellent, it was sometimes dangerously wrong, and the speed of it was entirely outside any regulatory framework that had been designed to handle it. The TikTok Ozempic conversation has its own internal ecosystem, distinct from the celebrity gossip conversation and distinct from the clinical literature, though it draws from both. On one side of the platform, creators with large followings documenting their weight loss journeys on the drug, week by week, with before and after comparisons that are honest and vulnerable, and that have, for many viewers, normalized the experience of using medical treatment for weight management in a way that decades of public health campaigns never managed. These creators describe their side effects candidly. They discuss the cost. They navigate the coverage battles on camera. They talk about food noise. They talk about what it feels like to eat differently. The content is, in its way, a form of public health education, even when it is also inevitably a form of personal performance. On the other side, the misinformation. Videos claiming semaglutide causes cancer, based on a rodent study involving doses far beyond human therapeutic range, with limited relevance to human use, misrepresented systematically. Videos claiming the drug permanently damages the stomach, claims about dosing and administration that contradict prescribing guidelines, the compounding pharmacy promotions, with varying degrees of transparency about what their products actually contain, the testimonials that look like medical advice from people with no medical training, reaching audiences of millions. Regulatory agencies are not equipped to moderate social media content at speed. The FDA issues warnings. Individual videos stay up. The platform's moderation is inconsistent. The information environment around the drug is, by any reasonable measure, chaotic. What TikTok accomplished, for better and worse, was to collapse the distance between pharmaceutical development and public consciousness in a way that had not happened before with a drug of this type. GLP-1 drugs went from clinical trial results to cultural reference point in a matter of months. The speed of that transition created genuine problems: supply shortages driven by demand spikes, prescribing occurring outside of appropriate clinical frameworks, misinformation circulating at scale. But it also created something valuable: a public conversation about obesity, metabolism, and the neurological basis of hunger that had never previously penetrated popular culture at that depth. The conversation was messy and frequently wrong in its details. The subject matter was important. Both things were true at once. As the cultural conversation around Ozempic grew louder, clinicians who worked with patients with eating disorders began raising concerns. The drug's mechanism, reducing appetite, quieting food noise, making eating feel less urgent, could, in certain contexts, be dangerous rather than helpful. For someone with restrictive eating patterns or a history of disordered eating, the appetite suppression could tip something delicate in the wrong direction. Eating disorder specialists called for better screening, better clinical protocols, more careful prescribing. It was another reminder that a drug interacting with something as psychologically loaded as hunger and eating was not a simple intervention, even when it worked exactly as designed. The relationship between GLP-1 drugs and eating disorders is complicated by the heterogeneity of eating disorders themselves. Anorexia nervosa, bulimia nervosa, binge eating disorder, and avoidant restrictive food intake disorder are distinct conditions with distinct mechanisms, and the implications of GLP-1 drug use differ across them in ways that are not yet fully understood. For binge eating disorder, characterized by recurrent episodes of eating large quantities of food in a short time, often accompanied by a loss of control, the appetite modulating and reward system effects of semaglutide may be genuinely therapeutic. Small studies and case reports have suggested that some patients with binge eating disorder experience reduction in binge episodes on GLP-1 drugs, consistent with the broader evidence that these drugs reduce compulsive food-seeking behavior. For patients with restrictive eating disorders, the picture is more concerning. Anorexia nervosa involves severe food restriction and distorted body image, and the appetite suppression caused by semaglutide could reinforce and intensify existing restrictive behavior in these patients. Several case reports documented dangerous weight loss in patients with anorexia who are prescribed GLP-1 drugs, sometimes by practitioners who are not aware of the eating disorder history, sometimes in the context of telehealth prescribing with limited clinical oversight. The drug was not designed to treat anorexia. In the context of anorexia, it could be actively harmful. Eating disorder specialists called for standardized screening protocols, questions about eating history, dieting behaviors, and relationship with food as a prerequisite for GLP-1 prescribing. They called for training for primary care physicians and telehealth platforms on eating disorder recognition. They called, more broadly, for a recognition that prescribing a drug that fundamentally alters the relationship with food carries psychological as well as physical implications, and that the two cannot be cleanly separated. The physical and the psychological dimensions of eating are not parallel tracks, they are the same track, running through the same person. Treating the physical without attending to the psychological is, in the context of a drug this powerful, a significant clinical oversight. The eating disorder community was not saying the drug was bad. It was saying that the drug required more careful handling than it was always receiving. In 2023, a major clinical trial produced results that reoriented the entire Ozempic conversation. The SELECT trial, which followed people with cardiovascular disease who did not have diabetes, found that semaglutide reduced the risk of serious cardiovascular events, heart attacks, strokes, by 20%. This was significant beyond anything to do with weight loss. It suggested the drug might have direct cardiovascular benefits independent of its effect on weight, possibly through its anti-inflammatory properties or its direct action on heart and blood vessel receptors. Suddenly, the medical community was looking at semaglutide not just as a weight loss drug and not just as a diabetes drug, but as a potential cardiovascular medication, one with implications far broader than any of its original research had suggested. The SELECT trial, Semaglutide Effects on Cardiovascular Outcomes in People with Overweight or Obesity, was designed to test a hypothesis that had been building in the research community for several years. The SUSTAIN-6 trial, which had established the cardiovascular safety of Ozempic for diabetic patients, had shown a reduction in cardiovascular events that was stronger than most researchers had expected. The question was whether that benefit extended to people without diabetes, a much larger population, and one that constituted a large proportion of patients who might be candidates for GLP-1 drugs for weight management. SELECT enrolled over 17,000 participants with established cardiovascular disease and BMI above 27, none of whom had diabetes, and followed them for a median of approximately 3 years. The 20% reduction in major adverse cardiovascular events, the composite of heart attack, stroke, and cardiovascular death, was both statistically robust and clinically significant. A drug that reduces cardiovascular events by a fifth in a high-risk population is, by any standard, a meaningful cardiovascular intervention. What was particularly striking was that the benefit appeared to be partially independent of the amount of weight lost. Patients who lost modest amounts of weight on semaglutide showed cardiovascular benefit comparable to those who lost larger amounts, suggesting that the drug's cardiovascular mechanism was not purely a downstream consequence of weight reduction. Something else was happening, likely related to the anti-inflammatory effects of GLP-1 receptor activation, or to direct effects on cardiac and vascular tissue, or both. The implications of the SELECT findings extended well beyond the obesity medicine and endocrinology communities. Cardiologists, who had not previously had a strong reason to be interested in GLP-1 drugs, began paying close attention. If semaglutide was a cardiovascular drug that also caused weight loss, rather than simply a weight loss drug that happened to have cardiovascular side benefits, the population of patients who might benefit from it was vast. Cardiovascular disease is the leading cause of death globally. A drug that reduces its event rate by 20% in high-risk individuals is not a niche treatment. It is a candidate for broad clinical application. The SELECT results did not resolve the access, cost, and coverage questions, but they changed the nature of the argument. While the United States and Western Europe were consumed by debates about celebrities, insurance coverage, and supply shortages, the majority of people in the world with type 2 diabetes had no access to semaglutide at any price. The drug's list price in the United States, among the highest in the world, was a fraction of what most people in low-income countries could afford, even with aggressive tiering. Generic versions could not be produced while patents held. The global burden of type 2 diabetes falls disproportionately on lower-income countries, on populations in South Asia, Sub-Saharan Africa, and Latin America where the disease is growing fastest. The existence of a highly effective treatment that was, for structural and economic reasons, available mainly to wealthy nations was not a new kind of injustice. It was a very old one wearing a new label. The epidemiology of type 2 diabetes tells a story that inverts the one being told in Western media. The popular narrative around Ozempic is heavily American and European, centered on celebrity, on insurance battles, on the cultural politics of weight and body image in wealthy societies. But type 2 diabetes is growing fastest in exactly the places that are least likely to benefit from new pharmaceutical treatments anytime soon. India has approximately 100 million people with diabetes, the second largest diabetic population in the world. China's number is higher still. Sub-Saharan Africa's diabetic population is projected to more than double by 2045. Brazil, Mexico, and the nations of Southeast Asia face rapidly rising prevalence driven by urbanization, dietary transition, and reduced physical activity. These populations carry the burden of the disease. They will not, at current pricing and patent timelines, carry the benefit of the treatment in any meaningful time frame. The economic gap is not subtle. In the United States, the list price of Ozempic sits around $900 per month. Even accounting for Novo Nordisk's tiered pricing arrangements in lower-income countries, arrangements that exist and that do reduce cost in certain markets, the drug remains financially out of reach for the vast majority of people in low-income nations. The average annual healthcare expenditure per person in sub-Saharan Africa is a fraction of what a single month of semaglutide costs at any tier. These are not merely uncomfortable numbers. They are a description of a world in which the people most affected by a disease have the least access to the treatment for it. That inversion is not new to medicine. It recurs reliably with almost every pharmaceutical advance of the past half-century. HIV medications, hepatitis C cures, cancer immunotherapies. Each time the pattern is the same. A drug is developed, primarily with wealthier country markets in mind, priced to recover investment and generate profit in those markets, and made available to lower-income populations years or decades later, if at all, through a combination of philanthropic pressure, patent expiration, and the slow machinery of international health policy. Novo Nordisk has made commitments that go beyond pure market logic. The company has participated in tiered pricing arrangements and has made public pledges to expand access in specific lower-income markets. They have worked with international health organizations on access frameworks. These efforts are real, and dismissing them entirely would be unfair. But they are also insufficient structurally to bridge the gap between what the drug costs to produce and distribute and what the populations most in need of it can pay. Philanthropy and tiered pricing are instruments that soften the edges of a system whose fundamental architecture generates this outcome. They do not change the architecture. The patent question is where the longer-term access story will be written. Semaglutide's key patents are expected to begin expiring in the late 2020s and into the 1930s. When that happens, assuming generic manufacturers in countries like India and Bangladesh, which have significant pharmaceutical manufacturing capacity, move to produce biosimilar versions, the price could fall dramatically. This has happened with other biological drugs. Insulin itself, once brutally expensive and patent protected, became far more affordable in many markets following patent expiration and generic competition. The same trajectory is possible for semaglutide. Whether it actually reaches patients in lower-income countries, when it does depends on factors beyond price alone: regulatory capacity to approve and monitor generics, healthcare infrastructure to deliver injections and monitor patients, and the political will of governments to prioritize metabolic disease treatment in national health budgets that are already stretched thin. There is also the question of what comes before patent expiration, the 10 to 15 years during which the drug is available and effective and priced beyond reach for most of the world. Those are not abstract years. They are years in which people with type 2 diabetes in lower-income countries will develop cardiovascular complications, kidney disease, and vision loss that might have been prevented or delayed by access to a drug that exists and works and that wealthy people on the other side of the world are losing weight on for cosmetic purposes. The moral weight of that disparity does not distribute itself evenly. It sits on specific people, in specific bodies, in specific countries who have done nothing to deserve less access to medicine than people born elsewhere. The Ozempic story, told in its entirety, is not a story about celebrity or insurance, or even about a remarkable drug. It is a story about how the world decides who gets to benefit from medical progress. The decision is not made in a single room by a single actor. It is the aggregate output of patent law, pharmaceutical economics, healthcare financing, trade agreements, and political priorities across dozens of countries over decades. It produces, reliably and predictably, the same result. More for those who already have more. The Gila monster pointed at something that could help everyone. The system ensured it reached some people first and others much later, if at all. That is not a footnote to the Ozempic story. It is one of its central chapters. In the middle of all the celebrity gossip and political theatre and supply chain drama, there were people who had spent 20, 30, 40 years of their lives working on GLP-1 biology in the quiet certainty that it mattered before anyone agreed with them. John Eng, who discovered Exendin 4 in Gila monster saliva, fought for years to get his compound taken seriously. Jens Juul Holst, who kept publishing on GLP-1 long after it was fashionable. A small army of pharmacologists, biochemists and endocrinologists, whose names appear in papers that nobody outside their field has ever read. The Nobel Prize conversation has circled the GLP-1 field with increasing intensity. Whether it arrives or not, the people who did this work built something that will affect human health for generations. From a lizard, from a gut hormone, from decades of unfunded stubbornness. Start with Jens Juul Holst, because his story is in many ways the spine of this one. Born in Denmark in 1942, Holst completed his medical training and moved into research at a time when gastrointestinal hormones were a specialist backwater, a field that attracted people interested in digestion rather than people interested in glory. His early work focused on the hormonal control of the pancreas. By the early 1980s, he was publishing on GLP-1 in the context of its role in insulin secretion, methodical, careful papers that established what the hormone did, how it was released, and why it was physiologically significant. He was not the only person working on GLP-1, but he was one of the most persistent, and persistence in science is often more consequential than brilliance. Holst gave talks at conferences where the audience was small and the questions were polite but not urgent. He applied for grants in a research climate where gut hormones competed for funding with cancer research and cardiovascular medicine and did not always win. He trained students and postdoctoral researchers who went on to work in the field, expanding the network of people who understood why this obscure hormone mattered. By the 1990s, when the pharmaceutical industry was beginning to take GLP-1 seriously, his laboratory was one of the foundational sources of the mechanistic knowledge they were building on. He was not a company man. He was not a rich man. He was a scientist who had been right about something important for a very long time before the world caught up. Joel Habener and Graham Bell at Massachusetts General Hospital contributed the molecular biology, the characterization of the glucagon gene, and the discovery that its processing in the intestine produced GLP-1 rather than glucagon. This was a finding of fundamental importance, establishing that GLP-1 was not a pharmacological oddity, but a physiologically real hormone produced by a well-understood genetic mechanism. Daniel Drucker at the University of Toronto spent the 1980s and 90s establishing GLP-1's role in pancreatic beta cell function, not just insulin secretion but beta cell survival, growth, and protection from the kind of exhaustion that contributes to diabetes progression. Drucker's work created the scientific basis for the therapeutic hypothesis that stimulating GLP-1 receptors could do more than lower blood sugar, that it might protect the very cells responsible for blood sugar regulation. That hypothesis turned out to be correct in ways that extended far beyond the pancreas. Svetlana Moisov at Rockefeller University contributed to the characterization of GLP-1 structure and its activity at the receptor level. work that was foundational in establishing what the molecule actually was and how it behaved. Her contributions to the field were significant enough that her name features in the history of GLP-1 research, and understated enough that she remained largely unknown outside it for decades. The history of science is populated by moisofs, people who did essential work that others built upon, received partial credit at best, and watched later contributors receive recognition more proportional to commercial success than to foundational contribution. The Nobel Prize question hovers over this field because the work is clearly of Nobel caliber. The GLP-1 drugs have already affected more people, more measurably, than many discoveries that have received the prize. The candidates most discussed, Holst, Habener, Drucker, each have legitimate claims to recognition. But the prize can be shared among at most 3 people, and the people who contributed to this discovery number in the dozens. The selection, if it comes, will necessarily be a simplification. It will tell a 3-person story about a discovery that required many more people than that, working across more institutions, more countries, and more decades than any 3-person narrative can contain. What deserves to be said plainly, in any account of what Ozempic is and where it came from, is this. The drug exists because people chose to spend their careers on questions the world had not yet decided were important. They made that choice without knowing it would pay off, without assurance that it would be recognized, and in many cases without adequate funding or institutional support. The courage required to work on an unfashionable problem for 30 years, to keep publishing, keep presenting, keep insisting that the answer is in the gut hormone that disappears in 2 minutes, is a specific kind of courage that the culture does not celebrate nearly as loudly as it celebrates the end products of that courage. The scientists who built this field deserved their moment. Most of them got a quiet one, if they got one at all. The drug they built got the louder one. That is how it usually goes. It should not go that way, but it usually does. Let's take a slow, quiet moment to understand, because it is genuinely remarkable what semaglutide is doing inside a human body once a week when someone clicks that pen and injects it. It binds to GLP-1 receptors throughout the body. In the pancreas, yes, but also in the brain, the heart, the kidneys, the gut. In the pancreas, it prompts insulin release in response to food. In the stomach, it slows the rate at which food empties into the small intestine, extending the feeling of fullness. In the brain, specifically in areas governing reward, appetite and satiety, it does something less fully understood but profoundly felt by patients. The background signal pushing toward eating becomes quieter. The reward system's response to food cues seems to dampen. It is not simply suppressing hunger. It is altering, in some fundamental way, the conversation between the body and the brain about food. The week-long journey of a semaglutide dose begins at the injection site, typically the abdomen, the thigh, or the upper arm, where the drug is absorbed slowly into the subcutaneous tissue and then into the bloodstream. Its attachment to albumin means it circulates rather than being rapidly cleared, maintaining a steady concentration across 7 days. Peak plasma concentration occurs roughly 24 to 48 hours after injection, then declines slowly through the remainder of the week until the next dose is administered. The consistency of this concentration profile, unlike the rapid peak and trough of many medications, is part of what makes semaglutide physiologically smoother than earlier GLP-1 drugs that required daily dosing and produce more pronounced swings. The body is not being jolted once a day. It is being held, steadily, in a slightly altered hormonal state, for the duration of the treatment week. At the pancreatic beta cells, semaglutide's activation of GLP-1 receptors triggers a cascade of intracellular signaling that results in insulin secretion. but only in the presence of elevated blood glucose. This glucose dependency is a critical safety feature, and it is worth dwelling on because it represents one of the ways semaglutide is genuinely superior to older diabetes treatments. Sulfonylureas, for instance, push insulin production regardless of blood sugar levels, which can drive glucose dangerously low, particularly if a patient misses a meal or exercises unexpectedly. Semaglutide does not do this. The pancreas is being told to respond to glucose, not to produce insulin into a vacuum. The result is a more physiological pattern of insulin release, closer to what a healthy pancreas does naturally, that provides control without the constant risk of hypoglycemia that shadows older drug classes. Beyond insulin secretion, semaglutide's effects on the pancreas include protection and possible regeneration of beta cells themselves. Daniel Drucker's early research suggested that GLP-1 receptor activation supports beta cell survival and may stimulate the growth of new beta cells from precursor cells in the pancreatic tissue. In animal models, this effect was robust. In humans, the evidence is less clear. The pancreas is not easily biopsied, and beta cell mass is difficult to measure in living patients. But the clinical data showing sustained improvement in blood sugar control over years of treatment is at least consistent with the hypothesis that the drug is doing something beyond simply stimulating existing cells. It may, in some sense, be slowing the progressive beta cell loss that is a feature of type 2 diabetes. That is a remarkable possibility for a drug that was initially characterized primarily as an insulin secretagogue. In the stomach and small intestine, semaglutide slows gastric emptying, the rate at which food moves from the stomach into the digestive tract. This has multiple consequences. It extends the physical sensation of fullness after eating, because food stays in the stomach longer, and the stretch receptors that signal satiety remain activated for an extended period. It flattens the postprandial blood sugar spike, because glucose enters the bloodstream more slowly when food moves through the digestive system at a reduced pace, and it contributes, alongside the brain effects, to the overall reduction in food intake that patients experience. Eating becomes less urgent, partly because the stomach still feels occupied from the previous meal. This is not a dramatic effect, it is a subtle physiological modulation. But small shifts in appetite and eating behaviour, maintained consistently over months, produce large cumulative differences in caloric intake and body weight. In the brain, the picture grows considerably more complex and considerably more interesting. The arcuate nucleus of the hypothalamus, a structure roughly the size of a small almond, buried deep in the centre of the brain, contains a dense population of GLP-1 receptors and is one of the primary nodes in the neural network governing appetite regulation. When semaglutide binds to receptors there, it activates pro-opiomelanocortin neurons that signal satiety, and suppresses neuropeptide Y neurons, which drive hunger. The hypothalamus integrates these signals with information from the stomach, the gut, the fat tissue, and the bloodstream to generate the overall appetite state. Semaglutide is shifting the balance of inputs to that integration consistently across the treatment week in the direction of satiety and away from hunger. It is not overriding the system, it is recalibrating it. But the drug's brain effects extend beyond the hypothalamus into territory that is both more consequential and less fully mapped. GLP-1 receptors in the nucleus accumbens and the ventral tegmental area, structures at the core of the brain's reward and motivation circuitry, appear to modulate the motivational salience of food. How strongly the brain's reward system responds to food cues, how urgently it signals for food-seeking behaviour. This is where food noise lives, neurologically. And this is where the most transformative experiences patients describe are happening. The food is still there. The visual cortex still processes it. the memory system still recognizes it, but the motivational weight the brain assigns to it, the pulling, pushing, insisting quality of food craving, has been reduced, not eliminated. Reduced to something manageable, something that feels like a choice rather than an imperative. For people who have never experienced food craving as anything other than an imperative, this description may sound simple. For the people experiencing it, it is anything but. By 2024, researchers were testing semaglutide and related GLP-1 drugs across a range of conditions that had nothing obvious to do with weight or diabetes. Preliminary results were emerging in addiction medicine. People on GLP-1 drugs reporting reduced cravings for alcohol, opioids, nicotine. Researchers studying Alzheimer's disease were looking at GLP-1 receptors in the brain with new urgency. Kidney disease, liver disease, sleep apnea, polycystic ovary syndrome, the list of conditions being studied grew monthly. Nobody was ready to call it a cure for everything, but the breadth of the findings reflected something the Gila monster research had hinted at decades earlier. GLP-1 receptors are woven through the body in ways that scientists were only beginning to fully map. The lizard, it turned out, had pointed at something very large. The addiction medicine findings arrived in the way that the most important GLP-1 discoveries tend to arrive. Not from planned experiments, but from patients noticing something their doctors hadn't anticipated. The pattern was consistent across substances and across patient populations. People on semaglutide for diabetes or weight management began reporting, in clinical settings and in online communities, a reduction in their desire to drink. Not a decision to drink less, not the grinding effort of white-knuckled abstinence. A quieting of the wanting, the same phenomenology, described in almost identical language as the food noise reduction. The craving had become less insistent. The pull toward alcohol had weakened without any particular act of will. These reports accumulated across too many patients, in too many places, to be dismissed as coincidence or placebo effect. The preclinical evidence was already there, largely unnoticed by anyone outside the addiction field. Studies in rodents had shown that GLP-1 receptor activation reduced alcohol consumption, and that GLP-1 receptors in the ventral tegmental area and the nucleus accumbens, the core structures of the brain's reward circuitry, played a specific role in mediating the rewarding effects of alcohol. Similar findings existed for opioids, for nicotine, and for stimulants. The mechanism was consistent with what was being observed for food. The same reward circuitry that drives compulsive eating appears to drive compulsive substance use, and GLP-1 receptor agonism modulates that circuitry in ways that reduce compulsive behavior across categories. The specificity to food, which the drug had been designed around, was perhaps less specific than everyone had assumed. The target was not food. The target was compulsion. Clinical trials were launched. The Oasis trial examined semaglutide for alcohol use disorder. Other trials examined liraglutide and semaglutide for nicotine dependence and opioid craving. The results that had begun to emerge were mixed in their magnitude. Some studies showed significant effects, others more modest ones, but the direction was consistent. GLP-1 receptor agonism reduced substance craving and consumption in patient populations for whom existing treatments were inadequate. This is a population that is vast, undertreated, and carries an enormous burden of preventable illness and death. Alcohol use disorder alone affects hundreds of millions of people globally and is associated with liver disease, cardiovascular disease, cancer, and suicide at rates that represent a major public health catastrophe. If GLP-1 drugs offer even a partial treatment for alcohol use disorder, if they reduce craving and relapse rates to a meaningful degree, the implications for population health are comparable in scale to their implications for obesity and diabetes. The Alzheimer's research represents a different and perhaps even more speculative branch of the horizon, but one that serious researchers have been pursuing with genuine intensity. GLP-1 receptors are distributed throughout the brain in patterns that suggest functions well beyond appetite regulation. They are present in the hippocampus, the cerebral cortex, and the brainstem. Studies in animal models of neurodegeneration have shown that GLP-1 receptor agonism reduces amyloid plaque accumulation, protects neurons from oxidative stress, reduces neuroinflammation, and improves cognitive function in models of Alzheimer's disease. The biological plausibility of a neuroprotective effect is real, grounded in mechanisms that are well understood at the cellular level. What is not yet known is whether those mechanisms operate at the same scale in the human brain, in living patients, at doses that are clinically tolerable. 2 major clinical trials were underway by 2023. The EVOKE trial was examining semaglutide in patients with early Alzheimer's disease. The trial was large, well-designed, and would take several years to produce results. Nobody was promising a cure. Nobody was claiming that semaglutide would reverse established neurodegeneration. The hypothesis being tested was more modest, whether GLP-1 receptor agonism could slow the progression of early Alzheimer's disease by reducing the neuroinflammation and metabolic dysfunction that appear to contribute to its advance. Given that Alzheimer's disease currently has no disease-modifying treatments that work convincingly, even a modest slowing effect would be clinically significant. The bar is not impossibly high, it is simply unknown. Beyond diabetes, obesity, addiction, and neurodegeneration, the list of conditions attracting GLP-1 research attention continued to grow in ways that reflected the drug's systemic reach. Non-alcoholic steatohepatitis, a form of liver disease closely associated with obesity and metabolic syndrome, was showing promising responses to GLP-1 treatment in early trials, consistent with the drug's effects on hepatic fat accumulation and liver inflammation. Polycystic ovary syndrome, a hormonal condition affecting millions of women and closely tied to insulin resistance, was being studied in the context of GLP-1's metabolic effects. Sleep apnea, which is strongly associated with obesity and which causes cardiovascular and cognitive harm through chronic intermittent oxygen deprivation, was showing improvement in patients who lost weight on semaglutide. Chronic kidney disease, which progresses faster in the context of diabetes and obesity, appeared to be slowing in patients on GLP-1 drugs, with dedicated renal outcome trials producing early evidence of benefit that echoed the cardiovascular findings. The drug that had been designed for one thing was being tested for everything, not because researchers had lost scientific discipline, because the receptors were everywhere, and everywhere the receptors were, something interesting seemed to be happening. Here is where we are tonight. A drug that was designed to treat diabetes accidentally discovered to suppress appetite through a mechanism borrowed from a desert reptile refined over 4 decades by scientists most people have never heard of, approved quietly in 2017, weaponized by the internet in 2022, debated in Congress, rationed at pharmacies, injected by celebrities and diabetics and the desperate and the curious, is still, in the most literal sense, in progress. The long-term data is still coming in. The patents will eventually expire and generic versions will change the access landscape. This science of GLP-1 is still being written, and somewhere in a laboratory that looks nothing like a red carpet, a researcher is looking at a result they did not expect, from a question they barely knew to ask and thinking, that's interesting. The drugs in development behind semaglutide are more powerful, more targeted, and in some cases more physiologically sophisticated than anything currently on the market. Tirzepatide, the dual GIP and GLP-1 agonist, has already demonstrated weight loss results that exceed semaglutides in clinical trials. Behind it, triple agonists targeting GLP-1, GIP, and glucagon receptors simultaneously are in clinical development, with early trial results suggesting even greater efficacy. Oral formulations of semaglutide and its successors, which would eliminate the requirement for weekly injections and dramatically expand the population able to access treatment, are in various stages of development and approval. The trajectory of the drug class, in terms of both efficacy and accessibility, is clearly upward. What began as a once-weekly injection requiring refrigeration and a degree of medical engagement is already moving toward a daily pill, and after that toward formulations that may need to be taken even less frequently. The inconvenience is shrinking. The results are growing. The question is not whether better drugs are coming. They are coming. The question is who they will reach, how quickly, and at what cost. And that question has a long and uncomfortable history of being answered in the same disappointing way. The long-term safety questions remain open in ways that deserve honest acknowledgement, not as a source of alarm, but as a straightforward recognition of what medicine knows and does not yet know. Clinical trials, even large ones, have finite duration. The pivotal STEP trials ran for 68 weeks. The Select Cardiovascular Outcomes trial ran for approximately 3 years. These are substantial timeframes by clinical trial standards, and the data from them is robust and reassuring. But they are not lifetimes. The patients who will be on these drugs for 10, 20, 30 years, maintaining treatment for what is now understood as a chronic condition requiring ongoing management, are currently accumulating the data that will answer questions no trial could have anticipated. Does long-term semaglutide use affect muscle mass in ways that become clinically meaningful over decades of continuous use? Does it affect bone density in aging populations? Are there cardiovascular effects, positive or negative, that only emerge with very extended use? Does the drug's modulation of brain reward circuitry have consequences over years and decades that shorter-term studies could not detect? Does it interact differently with aging physiology than it does with younger bodies, in ways that require different dosing or monitoring? None of these questions are raised to frighten. They're raised because medicine that is meant to last requires evidence that lasts, and the evidence is still being written in real time, in real bodies, by the millions of people currently on these drugs around the world. They are, in a very literal sense, the next chapter of the clinical literature. The cultural reckoning that Ozempic triggered is also unfinished, and in some ways barely started. The conversation about obesity, weight, and willpower that the drug forced into the open, the question of whether struggling with weight is a character failing or a neurological condition, whether people who use medication to manage it are taking a shortcut or treating a disease, whether thinness achieved through a drug is somehow less legitimate than thinness achieved through what the culture euphemistically calls lifestyle changes, has not been resolved. It has been sharpened. The stigma around obesity is centuries old and embedded not just in popular culture but in medical culture, in insurance policy, in the casual cruelties of daily life that people with larger bodies absorb continuously, and that the culture mostly pretends not to see. A drug that works does not dissolve stigma, but effective treatment over time tends to shift the moral framing of disease. HIV medications shifted the cultural conversation about AIDS, not all the way, not quickly, not without tremendous resistance and ongoing injustice, but perceptibly over decades, from a story about personal failing to a story about a virus and its management. Antidepressants shifted, partially and imperfectly, the cultural conversation about depression. Each time, effective pharmacology gradually undermines the argument that the condition is primarily a matter of character. That trajectory for obesity has begun. It has not concluded. The people who lived through the beginning of it, who were the first generation to say, out loud, that food noise was neurological and not moral, did something that will matter beyond their individual health outcomes. They changed the terms of a conversation that needed changing. There is something worth sitting with, quietly, in the middle of all of this. The discovery that produced Ozempic was not inevitable. It required a specific combination of curiosity and stubbornness that is rarer than science-funding bodies or pharmaceutical companies tend to reward. It required John Eng to spend years in the Gila monster's saliva when nobody thought that was a productive use of a scientist's time. It required Jens Juul Holst to keep publishing on GLP-1 through decade after decade of polite indifference from the broader medical community. It required Novo Nordisk to make a long-term commitment to a hormonal pathway when the commercial case was theoretical and the timeline was measured in decades rather than years. It required thousands of clinical trial participants to submit themselves to injections and monitoring and follow-up visits for the benefit of a dataset that would help people they would never meet. The drug that is now in the bodies of tens of millions of people was built, brick by unglamorous brick, by people who had no guarantee that it would work, no certainty that anyone would care, and no way of knowing that the thing they were quietly building would become the most talked about pharmaceutical in a generation. That is the shape of how important things happen. Not in a single moment, not in a single laboratory, not with a single name attached. In accumulated patience across accumulated years by people whose names mostly didn't make it into the headlines, and whose faces did not appear on magazine covers, and whose contribution to human health is, for all of that, completely real and completely lasting. What will remain long after the cultural moment has passed and the drug has become as unremarkable in a medicine cabinet as a blood pressure pill or a cholesterol tablet is the scientific understanding that made it possible. The understanding of how gut hormones communicate with the brain, how reward circuitry governs compulsive behavior across categories, how the body regulates energy, hunger, and satiety at a molecular level that is not a matter of moral character, but of chemistry. That understanding will outlast every patent dispute, every supply shortage, every celebrity confession, every congressional hearing, every before and after photograph. It is the most durable part of the story, and the part that will still be generating consequences in medicine, in addiction treatment, in neurology, in the basic science of how human beings relate to food and pleasure and wanting, long after everything else about this particular cultural moment has been forgotten. The Gila monster, somewhere in the desert tonight, is doing exactly what it always does. It is slow. It is still. It is conserving energy with an efficiency that evolution spent millions of years perfecting, wedged beneath a rock in the dark, waiting for something worth moving toward. It has no idea what it started. It does not need to. Its blood sugar is perfectly stable, its metabolism is running exactly as designed, and somewhere on the other side of the world, in laboratories and clinics and bedrooms and waiting rooms, a story that began with its biology is still unfolding, in the bodies of people who can finally hear themselves think without the constant noise of hunger. In the data accumulating in long-term trials that will answer questions we do not yet know how to ask. In the next generation of molecules and the one after that, built on the foundation of everything the lizard inadvertently pointed at. That is, as it turns out, how the best things usually happen, not by design, not by announcement, by curiosity, by stubbornness, by a scientist in the desert looking at an unremarkable animal and thinking, there is something in there worth finding. There always is. You just have to be patient enough, and stubborn enough, and willing enough to look for long enough. The Gila monster was, the scientists were, and the rest, slowly and improbably, and not quite finished yet, became history. And so, here we are. At the end of a story that began with a lizard in the desert and ended, if it has ended at all, somewhere in the middle of a revolution that nobody planned and nobody predicted, and that is still, even now, rewriting itself in real time. Tonight you travelled through 4 decades of science that the world ignored, through laboratories that nobody filmed, through clinical trials that nobody watched, through the quiet persistence of people who were right about something important before being right about it was fashionable or funded or famous. You travelled through the Gila monster's metabolism and a Danish scientist's stubbornness and a pharmaceutical company's long unglamorous patience. You travelled through shortage and inequality and celebrity and controversy and the strange, disorienting experience of millions of people discovering for the first time that the voice in their head demanding food was not their character, it was their chemistry, and that it could be turned down. That last part is worth sitting with as you drift off tonight, because it says something about how little we understand ourselves and how much is left to understand. For decades, people who struggled with their weight were told, in 100 different ways, that the problem was personal, that they lacked discipline, that they needed to want it more, that the solution was somewhere in the gap between who they were and who they could be if they simply tried harder. And then a drug came along and demonstrated, in clinical trials and in the lived experience of millions of patients, that the gap was never a moral one, it was a neurological one. The hunger was real, the noise was real, the difficulty was real. And it was not, and had never been, a failing. It was a signal that could now, for the first time in human history, be gently, chemically, asked to quiet down. There is something deeply human about this story, underneath all the science and the controversy and the celebrity gossip. It is a story about suffering that went unnamed for a very long time, about a problem that the culture preferred to moralize about rather than investigate, about the slow, grinding work of people who chose to investigate it anyway, in the face of indifference and inadequate funding, and the polite skepticism of conference rooms when nobody moved to listen. It is a story about what happens when science is patient enough, and stubborn enough, and lucky enough to find the thing it was looking for in a place nobody thought to look. A desert, a lizard, a hormone that disappeared in 2 minutes, a molecule that turned out after 40 years of careful engineering to be something close to an answer. Not a perfect answer. Medicine does not produce those. It produces better answers, incrementally over time, with side effects and caveats and long-term questions still outstanding, and access problems that require more than science to solve. The story of Ozempic is not a triumphant one, cleanly. It is a complicated one, honestly. A drug that works in ways that matter, that reach some people who needed it, and missed many more who needed it equally, that became famous for the wrong reasons before becoming understood for the right ones, that is still accumulating evidence and generating controversy, and being refined by the next generation of researchers who inherited a foundation they did not have to build from scratch. That is what progress looks like when you see it up close, not a clean arc, a tangle of threads, some of them beautiful, some of them troubling, all of them real. So tonight, as you sink into your clean and comfortable bed, in a room with a controlled temperature and clean water available at the turn of a tap, take a quiet moment to feel grateful for the unglamorous people, the ones who published papers nobody read, the ones who gave talks to half-empty rooms, the ones who filed patents for Gila monster saliva and spent years being politely told that was probably not going anywhere, the ones who ran clinical trials and monitored patients and crunched numbers and wrote the foundational literature that made everything that followed possible. They did not do it for the magazine covers. They did not do it for the stock price. They did it because the questions interested them and the suffering was real and the distance between those two things seemed like a gap worth trying to close. History is full of those people, We do not know most of their names. We benefit from all of their work. Every treatment that keeps you or someone you love a little healthier, a little longer, traces its lineage back to someone who stayed in a laboratory when they could have done something more visible. Someone who believed in a hormone. Someone who would not let the idea go. Let that settle over you now. The gratitude and the warmth of it. The quiet miracle of living in a time when so many of the things that would have killed your ancestors are manageable, treatable, survivable. When the gap between suffering and relief is smaller than it has ever been in human history, and getting smaller still, one stubborn scientist at a time. The desert is quiet tonight. The lizard is still. And somewhere a researcher is reading a result that surprises them in a field that didn't exist 10 years ago, asking a question that nobody has asked before. The story isn't over, it is just resting. Like you, close your eyes, you've earned it.